All right, guys, thanks for joining me. I'm Kevin Travis with Master Medics, and today we're going to talk about the BRASH syndrome. We've got a good case review for you. First, don't forget, you can start a free 3-day trial at mastermedics.com. We have all kinds of content for paramedics, EMTs, ACPs, PCPs, basically all kinds of stuff to be able to get you either through school, videos, practice tests, stuff like that. We also have content like case reviews and whatnot to kind of help you as a first, second year paramedic trying to get your way through, mastering the topics and stuff like that. So be sure to check out mastermedics.com. Any membership you sign up for, the first 3 days free, cancel it. We don't charge you a thing. All right, let's get on with it. So here's our case. Clarice is 82 years old. She's had diarrhea for 3 straight days. So we already know she's probably volume depleted, potentially has an infection or something like that, right? She called for progressive weakness. She just states she just generally does not feel well. So just kind of a general malaise. A lot of these kind of sepsis-y types patients, they often just call with a general illness, right? All right, so the past medical history is high cholesterol, hypertension, CHF, and atrial fibrillation with daily meds of Simvastatin, atenolol, lisinopril, and 81 milligrams of aspirin. Now, as we talk about BRASH syndrome, I want you guys to keep note of atenolol, which is a beta blocker, and then lisinopril, which is an ACE inhibitor. Okay, so as we talk about it, think of those two things on this patient. Here are our vital signs. Bradycardic at 46, hypotensive at 84/56, SpO2 is good at 95%, end-tidal CO2 is a little bit low at 30, so that's not screaming sepsis to me. So there might be something else going on here that's causing that low heart rate and that low blood pressure. Temperature is 96.6, so does potentially have an infection here, right? And then BGL of 70, so it's not hypoglycemia. Here's our ECG. Very slow. So if you guys know how I like to do ECGs, is I do rate, rhythm, and then P, Q, R, S, T. Okay, so let's look at our rate. Our rate is very slow. Our rhythm is very regular, so it's not atrial fibrillation. So our rhythm, we'll put a check mark there. We're good to go there. P, I don't see P waves throughout this entire thing, okay? So I'm going to put a little exclamation point. Something's going on there. Q, our QRS width is actually very good. It's not wide at all, which is a little bit suspicious. Okay, so we have a very narrow QRS. So that's good. R waves, our R wave progression, we start down and then we get back up right here. That's all right. I'm not seeing anything massive there. We're starting to see a lot of high voltage here, has a history of CHF, so potentially also has some LVH, right? Okay, so we're looking pretty good there. Now S, we don't have any ST segment elevation, anything like that that I'm seeing anywhere. So we're good there. And now T waves. T waves, I want you guys to pay attention right here, right here, right here. We've got the shape of that tent, right? The teepee. All right, if your T's are teepeed, that means hyperkalemia, right? Some people call them the skyscraper T waves. So especially here and here, we can really see they've got that nice, even on both sides, parallel morphology. It's not tilted one direction or another. That's pretty indicative of hyperkalemia, all right? So we have very slow rate. We have no P's that are visible, potentially some P's that are buried in the T waves back here. So maybe there's something junctional going on there. We have AV nodal blockers in there if we have beta blockers. So it could have to do with that. And then T waves are tented and big. Okay. All right. So this is all symbolic of BRASH syndrome. Everything that I just gave you here. Let's talk about what BRASH syndrome is. So BRASH, our rate is low. The B stands for bradycardia. Okay. The R is for renal, and that's renal dysfunction or renal failure. All right. Right here, our AV node, we have an AV nodal blocker on board. So this could be a beta blocker, it could be verapamil, diltiazem, maybe a calcium channel blocker as well as that beta blocker, right? This is, the S is for shock. So the patient is exhibiting signs of hypoperfusion. We saw that blood pressure, 84/56, I believe it was, really low, very shocky, right? And on top of that, the H is for hyperkalemia. So hyperkalemia, again, is high potassium in the bloodstream. All right. So the pathophysiology of BRASH is very, very, very interesting. One of these things goes wrong, and when one of those things goes wrong, it ends up causing this massive cascade, okay? So let's start right here with the beta blockers. So the beta blockers, they cause that slow heart rate, all right? On top of that, some beta blockers can also cause hyperkalemia. We'll talk about that in a second. So that bradycardia causes hypoperfusion or shock, right? That hypoperfusion or shock ends up actually causing problems with the kidneys, right? We don't have enough perfusion to the kidneys. What ends up happening? The kidneys stop functioning. They stop getting rid of waste. They stop eliminating medications. One of those medications might be your beta blockers, right? So that means that our beta blockers start to stack up. We get increased numbers, increased quantities of that beta blockers because instead of our body, secreting it over time, it ends up, building up inside of our body. On top of that, when the kidneys fail, we increase our potassium levels because we can't get rid of our potassium either, right? So we've got that high potassium, which also causes bradycardia. So this is all intermingled right here. You've got, poor perfusion of the kidneys, which is causing hyperkalemia, which causes bradycardia, which causes shock, hypoperfusion to the kidneys, which then causes the kidney failure, and it's a vicious circle. And on top of that, the beta blockers themselves, or the calcium channel blockers themselves, the AV nodal blockade is causing a much worsened problem, an exacerbated problem of this. And truly, that is the key to this entire equation of BRASH, is that AV nodal blockade that's basically potentiating everything else that's going on right in front of us. On top of that, ACE inhibitors can also cause problems with hyperkalemia and also cause problems with those kidneys, all right? So we have lisinopril on board and we have atenolol on board. Lisinopril, ACE inhibitor, and beta blocker is atenolol. So this patient likely has BRASH, right? So what is the treatment for BRASH? Do we use our ACLS algorithms? No, we do not use our ACLS algorithms. Why don't we use our ACLS algorithms? Because this doesn't fit ACLS algorithms. I don't see calcium up on here. I see transcutaneous pacing on here too, and that's not going to help out with this patient, right? So we need to, for this specific patient presentation, we need to look for the H's and T's, identify BRASH, and then move on to the correct treatments. Now our correct treatments, pretty easy actually. You look at that hyperkalemia, which is the most likely portion of this to cause a patient to go into cardiac arrest, right? That can be treated by calcium gluconate by stabilizing the myocardium, okay? On top of that, lactated ringers is going to help with the hyperkalemia, help with the fluid replacement for that shock, and it's also a renal protective fluid for that fluid resuscitation. So lactated ringers is going to be your moneymaker to help with all three of these things, okay? On top of that, epinephrine, so an epinephrine drip, all right? That epi is going to help with your rate. Epi also helps with the AV nodal conductivity. So it helps counteract the fact that we've got a blockade in the AV node because epinephrine actually increases the conductivity of the atrioventricular node, all right? On top of that, by increasing our systemic vascular resistance with that epinephrine, we also are going to help perfuse those kidneys better, right? Which in turn helps with shock. So these three things are going to be truly our priority in this patient right here. So fluid resuscitation, an epinephrine drip, and calcium gluconate, all right? If we have a little bit more time, we can also add in there an albuterol inhaler or an albuterol nebulizer. Albuterol helps basically with the transportation of potassium from the serum into the cell. All right. On top of that, furosemide helps with the excretion, or Lasix, helps with the excretion of that potassium through the kidneys. But the caveat is we do have to have our volume replaced before we start jumping into furosemide. So this is going to be something that's going to be on a longer transport or might be initiated in the hospital, okay? Our priorities in the pre-hospital setting are going to be these three, and then potentially that, okay? All right, that's BRASH. It's pretty easy to understand. It's going to be harder for you guys to identify in the field. Don't forget, you're going to be looking for all those signs and symptoms of that AV nodal blockade, so that really low, slow heart rate. Hyperkalemia, those tented T waves. You're going to look for that history in the patient's medication list that says that they have diltiazem, they have a beta blocker on board, stuff like that. Look for those signs of shock, all that kind of stuff. All those 5 things that I just highlighted up there, okay? All right. Thanks for joining me for a BRASH case review. If you guys have any questions, please feel free to message us at the Paramedic Facebook page, on our website. You can go to mastermedics.com, message us on Instagram. Be sure to also follow us on TikTok. We have a pretty active TikTok now, and hope to talk to you guys soon. See you at the next case review.